Hello, we are from Group A3 and we are going to present a case study from a neuro high dependency ward with the diagnosis of a left putamenal bleed. Our group consists of 5 members. The first one, which is Erica Anak Blabun, which is the leader of our group. The second one is Vanessa Aya Anak Nyimbong. The third one is Ilya Izzati. Fourth one is Fatina binti Abdul Razak. And the fifth one is Muhammad Azamul Anik. Why we choose this case? This case was chosen because it is very interesting where an unknown cause affecting a patient to have a sudden weakness causing him to fall. The weakness causing a patient to a weakness to the left part of the leg and arm. Eventually, it is radiating to the all part of the left body patient. And this case required a high degree of clinical suspicion and careful management, as the cause might be originated from a central nervous system and brain, and the risk of further aggravating the brain and the central nervous system without a proper investigation and medical management can lead a total damage to the part of brain or the central nervous system and can affect a patient into an unconscious or affect the patient body system including respiratory and also cardiovascular.
The patient presented in our case is a 40-year-old male. He's a Chinese. He is married and lives with his family in Moyan Batu Kawa. Patient's chief complaint was a sudden onset of right body weakness when he was having a drinking session with his friends at a coffee shop. Patient presented with signs and symptoms of slurred speech, facial asymmetry, with drooping over his right side of the face, headache, and had one vomiting episode. He came to the hospital with a GCS score of 14, where he has a spontaneous eye opening and is oriented to time, place, and person. But the patient's motor response is localized to pain.
Greetings to the examiner. I am Fatina binti Abdul with matrix number of 73458. I will be presenting the health history and physical examination done onto this patient. So for this health history, this patient has underlying hypertension and he went to KK for his checkups, in which his systolic BP trend was 142 to 103 and 90 to 110 for his diastolic BP. He is a chronic alcoholic and an active smoker. He is also married and was blessed with a child. For the physical examination, upon arriving in ETD, his vital signs are taken and his blood pressure reading was 194 over 112, in which this shows a hypertensive crisis. He complained of sudden right body weakness, so a neurological assessment was done and noted that his right upper and lower limb has severe weakness. It was also noted that he has a slurred speech and presented with facial asymmetry, so GCS assessment was done and result was 14 out of 15. CT brain was done during his observation in emergency and it shows hemorrhage of the left basal ganglia. Based on the results of the significant assessments done, the left basal ganglia hemorrhage was due to hypertensive emergency, in which it causes the drop in GCS and right-sided body weakness. After interventions done in NHDU, his latest BP prior to discharge was 124 over 83 and his GCS was full.
For the third part, which is the disease process and a pathophysiology of the disease, firstly, the patient was diagnosed with underlying hypertension, was aggravated and worsened, and lead to a cerebral hemorrhage in the basal ganglia, precisely in the putamen area, which was the largest and the most lateral part of a basal ganglia. Putamen part, which is the area that is responsible in the learning and motor control, including speech articulation, language functions, reward cognitive functioning, and addiction. The hypertension in the brain causing the blood pressure in the lenticulostriate arteries, which is the LSA, located in the middle and anterior of cerebral arteries to be in a very high pressure. The pressure in the blood exceeds the threshold and causing a rupture producing intracerebral hemorrhage involving a large part of white matter in the brain. The hemorrhage in the brain can lead to very serious clinical syndrome, including enlargement hematoma, flaccid hemiparesis, rapid deterioration, comatose, frequently vomiting, ipsilateral dilated pupil, and ataxic respiration.
Next is for management and outcome. The first management is taking blood for the full blood count. And then the second is access for Glasgow Coma Scale GCS. Full GCS is 15/15 with eye 4, verbal 5, and motor 6. Next, monitor intake and output for the patients. Monitor vital signs such as blood pressure, heart rate, and SpO2. Checking for blood sugar level. Pupils monitoring. Send patient to CT brain. And patient allow orally with IV drip 1.5 liter per day all the saline. And the last one is keep patient in a normal intensive care. For the next management is the medications. First medication is IV lebetalol, which is a beta blocker. It is a vasodilation and decrease blood pressure. The next medication is tablet metoprolol, 25 mg, which is also a beta blocker to treat angina and hypertension. Next is tablet perindopril 8 mg. It is an angiotensin converting enzyme inhibitor, which is to relax and widen blood vessels. Next medication is tablet amlodipine, 10 mg, which is a calcium channel blocker, to lower blood pressure by relaxing the blood vessel. The last management for medication is tablet captopril, 12.5 gram, which is an angiotensin converting enzyme inhibitor to relax and widen blood vessel. For the outcome, first one is blood pressure in a normal level. So we can see the difference during the admissions and also the before discharge. So during admission is 194/112, and before discharge is 124 and 83. The second outcome is that the patient's skin is in intact condition.
For nursing diagnosis, we chose to do impaired physical mobility related to cognitive impairment as evidenced by inability to purposely move the right side of the body. Goals for this nursing care plan is the patient will be able to increase strength and function of the right side of the body in 3 days. Interventions for this nursing care plan are: first, to assess the patient's level of functional mobility and ability to perform activities of daily life, ADL. This is to assist in creating an accurate diagnosis and monitor effectiveness of treatment and therapy. Next, we elevate patient's arm and hand of the affected side to promote venous return and helps prevent edema formation. We also encourage patients to perform range of motion (ROM) exercises in all extremities. This is to improve venous return, muscle and stamina while preventing stiffness and contracture deformation. We also assist patients during exercises and when performing activities of daily living to encourage the patient to